All right. So what has wheels that transports you from one place to another? Who here initially thought cars? Hopefully most, right? Anyone think bike? And then anyone thinking airplane? Yeah, this guy, okay. So each one of these answers is correct. They have wheels, they transport you. And these answers also show us how we hold concepts of ideas and objects in our head. Ambiguity causes us to lean into our individual biases. When we also use this trait to explain new concepts to people. For example, most of us DPC docs have used Netflix as a way to explain to prospective patients how membership-based care works. In our local communities, we can shape how people think about DPC through networking and marketing. But as we enter the healthcare mainstream, more people are going to hear about us that have never heard about us, losing some control from how we shape the message. And because we're a relatively new kid on the block in the overall healthcare landscape, people are going to default to some of their individual biases. So heading into the spotlight means facing increased scrutiny on who we are and what we do. We're going to get faced with questions like the whatabouts. What about the poor? What about the elderly? We need to define who we are so that we can better address these questions and have people understand what our potential and what our role is. We'll also get asked to take on some of the larger challenges like the primary care shortage. And to answer that, will we continue to be a model that's largely dominated by small panels and one-to-one visits, or are we going to learn how to leverage technology and other professionals in order to deliver more care to more people? And finally, as we get into the mainstream, there's going to be a lot more eyes on us and a lot more opinions about us. Are we going to continue to stay in a corner congratulating ourselves, or do we make a habit to actively engage as many people as possible so that we can find those who are interested and correct our critics? In order to grow and enter the mainstream with this new phase, there are 3 areas we can focus on: definition, progression, and collaboration. Originally, the second word was innovation, but didn't make as good of an acronym. So, starting with definition. How we define ourselves has major implications. When Dr. Garrison Bliss first started this practice model, the Washington State Insurance Commissioner wanted to regulate it as health insurance. Just like when I said, what has wheels and transports you, most people thought car, the insurance commissioner heard monthly payments for healthcare services and reflex to health insurance. You still see this train of thought today with the IRS defining DPC as a health plan. How we define ourselves also affects how patients view us. So this is a frequently brought up topic in our space, and I'm curious with the audience here, how many of you think DPC and concierge medicine are interchangeable? Surprisingly few, okay. Oh, you got someone. So a lot of practices will lean into the concierge moniker because they know a lot more people understand what concierge is, and they associate it with high-touch, high-value care. Some others will actually call DPC concierge for the masses. I personally have taken the stance that DPC and concierge are wholly different. And the reason for that is because for everybody who understands what concierge is and the high touch, there are a lot more people who associate concierge care with exclusive, expensive care, whereas I like to present DPC as a model that is accessible for everybody. Recently, we've also gotten thrown into the alphabet soup of value-based care models. These are basically different flavors of capitation. But all of us here know that we're very different from all the other value-based care models. We established we're not concierge, and we for sure are not health insurance. Though recently I had to have a extended discussion with a former federal regulator on this topic, and after about 3 hours, using the Netflix analogy, I gained some ground by having him agree that Netflix, in fact, does not bear risk for entertainment services. So we need to better define what direct primary care is for ourselves and for those who become newly acquainted with the model. We can attempt to do this by breaking down direct and primary care. So starting with direct, there are some purists who believe that direct means you can only take payments from the patients that you see. But in the last several years, there's been large and increasing influence of employers helping to grow the DPC movement. And of course, employers paying for employees is a third party. On a smaller scale, if you have someone in the family paying for somebody else, technically they're also a third party. So direct doesn't mean no third party payer. Instead, direct is a separation of primary care services away from traditional health insurance. Primary care services, as a part of health insurance, are 100 years of historical momentum. When health insurance first started in this country, we had just discovered penicillin, and we were still 30 years away from knowing that high blood pressure and cholesterol were bad for us. A lot has changed since then. And the growth of the direct primary care movement is a natural separation of non-insurable services from the wrong financing vehicle. So, direct means no insurance. Stepping outside of the insurance world, we find ourselves with a host of other services, namely the direct-to-consumer ones. Those are the vanity companies helping with hair loss, erectile dysfunction, weight management. We have tech pods that will check your vitals, and there are virtual-only urgent cares. What defines direct primary care out of all those is the second part, primary care. I've heard that if you take 10 economists and you put them in a room, you'll end up with 11 opinions. Defining primary care is similar to that. When I go across the healthcare landscape, talking to people from policy, tech, finance, other clinicians, everybody has their own definition of what primary care is. And rather than just a definition, I prefer to use a framework. And my favorite one is authored by Dr. Barbara Starfield. It was mentioned in the first talk, which is the 4 C's of primary care. They are point of first contact, continuity, comprehensive care, and care coordination. In order to be true primary care, which is what direct primary care claims to do, we have to hit all 4 of these C's. So putting it together, direct primary care, direct, no insurance, primary care, meeting the 4 C's. We have this definition. DPC, a healthcare service that is not funded by insurance payments, which acts as the point of first contact and offers comprehensive, continuous care with care coordination. Now, this isn't meant to be the legal definition, and we can have a whole talk over how we define this with a bunch of subcategories, but this is simply to be used as a way to help categorize and understand the different services that are out there. So the next time somebody calls something a dyno, use this definition as a rough guide to whether or not it is, and then if somebody asks you about something they think is DPC, that's obviously not, like one certain medical company that was recently acquired, you can also use this to explain why it's not. While this definition delineates what is and isn't DPC, it also allows for some variety within it. We can think about health insurance as planes, which you would never use to drive from your house to the grocery store. And yet, that's what we're doing in the traditional healthcare system. DPC is a brand new distinct category of cars. And within cars, you have everything from the smart car to F-150, Lamborghinis to Camrys. And just like cars, there's a lot of variety in DPC. Family medicine has been the leading specialty in driving the growth of the DPC movement. But we're starting to quickly get joined by some of our colleagues. One of them is pediatrics. Pediatrics is faced with the same low insurance reimbursement and high administrative burden that family medicine face, and their numbers are growing very quickly. Other varieties include which clinicians deliver care, whether it's all virtual or in person, as well as price points, as low as 30-something all the way to above $500 a month. I've heard some people call something a dyno simply because they didn't agree with the style of care or with the price point. But we need variety. Doing things differently is the definition of innovation, and we have to innovate in order to progress our movement, which brings me to progression. So I was in residency when the Butterfly handheld ultrasound came out. Somebody in the DPC community said really nice things about it, and shortly after, everyone across the country all the DPCs had a butterfly ultrasound in their office. Compare that to the hospital system I was at the time. I got all excited, got myself one, hyped up the faculty, several of the faculty got theirs, which then triggered the hospital to form a committee to figure out how they could get reimbursed. Then, after much thought and deliberation, they decided to ban it completely. Compare that to more recently as well, there was an AI scribe that some DPCs liked, they talked about it, and once again, all across the country, everybody started using it. Our model allows for rapid innovation as well as implementation of new technology and new processes. And despite our advantages, a lot of DPCs still look more like planes without wings than their own category of car. So here are some ways that we can completely change how primary care is done. First is quality metrics. Quality metrics is a two-word phrase that might as well be a four-letter word to most doctors, especially the ones in DPC. So there's the emoji. Most mom and pop DPC practices have an anaphylactic reaction to the word metrics and refuse to participate in any efforts to prove quality. Those who are working with employers are often forced into measuring something so that they can maintain their contracts. But often these metrics are antiquated biometric ones, like how high is the A1C, blood pressure. There are other metrics that are seemingly logical but are equally useless, like engagement rate. We're lucky to have Dr. Rebecca Etz in the Larry Green Center, who spearheaded the person-centered primary care measure, which is what was talked about in the first talk this morning. This is a great example of how we can change what primary care means and how to measure what good primary care is. This survey captures the 4 C's of primary care, and everybody in the primary care space can agree that these metrics are meaningful, important, and deliverable. We cannot keep promoting how good DPC is as a model if we can't prove it. There are too many people right now who think that metrics and measuring things means using the old metrics dictated by insurance and the government. Well, guess what? They don't pay you anymore, so you don't have to use their measuring sticks. Think about, instead, what matters to you. Is it your response time? Track that, and then add that to conversations where people are complaining about how they can't reach their primary care doc for weeks or months. Is it your scope of care? Label times when you saved patients a referral or a trip to the ER and urgent care, and then insert that into conversations about total cost of healthcare. DPC allows us to redefine and reassess what good quality primary care means, and subsequently gives us the responsibility to measure those things and report that so that we can truly demonstrate our impact across the healthcare system. Medical education. So every couple months or so, somebody brings up the idea that we should have a DPC residency. But I haven't really heard any good ideas about what that means besides for residents should do DPC earlier. So medical students and residents absolutely need to hear about DPC early in their training. And that's part of our efforts at the Direct Primary Care Alliance through our Resident Medical Student Committee, or RAMS committee. Students need to see what the future of primary care is so that we can start to reverse the continued decline in primary care interest. That being said, a direct primary care residency is the wrong answer. Medical school is a time for students to learn as much textbook medicine as possible, both in the classroom and on the wards. Then, during residency, their main goal is to apply that knowledge in a real-life scenario with a supervisory safety net. There is value in volume at this stage. And also, practicing and training in a fee-for-service model helps people understand why DPC exists. Doing a DPC residency in the way that we currently think about it, which is longer visits with smaller panels, is not really a good fit. Instead, let's look at the level of fellowship. For those of you who are unfamiliar, fellowship is a stage of training where a doctor finishes residency and then can specialize even further. This is where internal medicine doctors become pulmonologists and cardiologists. Today, the most popular fellowships in family medicine are sleep medicine, sports medicine, and emergency or urgent care. Wait a second. This is a specialty that's designed to train people to do primary care just for them to pivot out and do not that. Something's wrong there. Fellowship is supposed to be a time that you double down on the specific knowledge set or base of knowledge from your specialty. And yet we see people leaving that. So in DPC, we have the ability to create fellowships that truly reflect the functions of primary care. DPC practices specialize most in care coordination and price transparency. We usually learn these skills on the job after we open our practices as we help our patients across the healthcare system. But we could potentially create and formalize training in these skills. What that could look like, a fellowship or a module in care navigation could teach you how to develop systems on how to best assess your specialists. It can teach you how to open lines of communication and share resources with your hospital systems. And it can help you understand what resources are out there for uninsured patients. A fellowship or module in price transparency can teach you how hospital prices work and how to compare them, the difference between ambulatory centers and hospitals, as well as the rights of patients to cash prices, whether or not they have insurance. Now, I bet a lot of DPCs here probably wish that they could have gone through a course like this. DPC doctors who are involved in medical education are key to transforming how we train our future primary care physicians and increase the effectiveness they have for their patients and on the healthcare system as a whole. Clinical practice. So scope of care. Scope of care simply means who gets to do what. It's one of the most controversial and contentious topics in all of healthcare right now. So without further ado, let's jump into it. Nurse practitioners and physician assistants have played crucial roles in medicine for decades. In certain specialties, they have more defined roles. For example, in bypass surgery, the surgeon will work at the level of the heart while the PA is at the leg, harvesting the vein, which will be used as the bypass vessel. Primary care is a little more tricky. PCPs tend to treat everything from urgent care to chronic care, the common cold, all the way to complex multi-organ disease. Further exacerbating this issue is a finance delivery system which uses non-discriminatory E&M codes, which incentivizes shorter visits and more referrals. This is why in most fee-for-service practices, you'll see a doctor and an NP or a PA working in parallel with little difference between their patient panels. They call NPs and PAs physician extenders, but really in this model, they're just profit extenders. So feeling a little heat, that's okay. I'm going to try to get some heat from the physicians as well. In DPC, many are following the same playbook. They have their own panel, and then they have an NP or PA who also has their own panel, and very little difference between them. Part of this reason is because most DPCs right now are run by middle of their career family docs who transitioned and have brought with them their habits from the system. And so they would rather have their own panel and do everything for everyone and supervise another panel doing everything for everyone rather than figuring out how to share a panel and divide the labor. More controversially, I believe today in primary care, about 60 to 80% of what is done by a physician can be done as well, if not better, by another profession. All right, I'm going to take some heat for that later. Great. Imagine instead a practice where a physician is seeing complicated and undifferentiated patients. Their nurse practitioner or physician's assistant is maintaining stable patients. The patient has a relationship with the entire care team, and they transition between the two as their needs change. Meanwhile, there's an open line of communication and dialogue. We're currently separated by a conflation of skills that arises from the immovability of habit and tradition. But I believe whoever can figure out how to practice in our model, which absolutely allows something like this to exist, can increase their patient panel without compromising the quality of care or the patient experience. Another underappreciated and underutilized colleague of ours in healthcare are the pharmacists. These folks spend 4 years in school earning a doctorate in deeply understanding the medicines that we prescribe every day. We trust them to catch our mistakes in the hospital. We consult them to ask questions about drug-drug interactions. So why are they not more actively participating in bedside care for our polypharmacy patients? These ideas aren't just ones I came up with last week. People are already doing them. Integrated systems like Kaiser already use clinical pharmacists at the bedside. Oak Street, a Medicare Advantage company, has its own nurse practitioner fellowship to better teach team-based care. DPC gives us the freedom to advance how care is delivered and by who. And with an innovative financing model, we need to innovate how we deliver care. All right, to cool things down a little bit, let's talk about tech. Tech, of all the things that I talked about, clinical care, quality metrics, medical education, tech can supercharge all of these things. But here's the key. Tech does not innovate anything itself. It simply charges what's already happening. Just look at the AI tools right now. We have AI tools that will speed up the prior auth process, AI tools that will scrape CPT codes out of clinician notes, and of course the ambient AI scribes. As the DPC community innovates, tech will be a natural partner to help supercharge these changes. The key to tech innovation in direct primary care is deeply understanding the unique aspects of our model and what our needs are, which requires collaboration. So, a rock becomes a foundation only if something is built on top of it. DPC is reshaping our healthcare system by using primary care as a foundation rather than health insurance. But we cannot build our shining city on the hill without others, and if we don't, we won't be a foundation, but simply rocks in a desert. So starting with the tech community again. In the early days of DPC, most practices used gym membership software because of its monthly billing capabilities. An early tech entrepreneur attended some of the first DPC summits and got captured by the mission and the spirit of the model. After getting to know the community better, he then went on to create a platform specifically for DPCs that completely replaced all the gym software. That young tech entrepreneur was Zach Holdsworth. Where's Zach? There you are. Yeah. Hint has contributed to and grown with the DPC movement. The success of the original product, along with the newer products, Hint Clinical and Hint Connect, happened because of Zach's close relationship with our community, as well as continued support to the movement through various channels, including this summit. Zach is a great example of how the tech community can engage with the DPC community to help solve our problems and grow our movement. But for every Zach out there, there's about a dozen people who don't really get that. I engage with a lot of tech people who want to build something for DPC, but have no idea what we're about or what we need. Even worse, there are some people who will just go online and scrape email lists of all the DPC practices and cold email everyone. That is actually pretty effective. If your goal is to be blacklisted immediately, have no shot here. On the flip side, clinicians can also do a better job of engaging the health tech community. Health tech tends to congregate in certain online communities like Health Tech Nerds and Out of Pocket. They also go to conferences like Health, spelled HLTH, and Vive. In these circles, they're talking about DPC already, and most of the time they're incorrect about what they're saying and what the needs are of our community. Clinicians who engage the health tech community can introduce them to our model and help better understand what we need. And on the flip side, the clinicians can also learn how technology can advance what they're already doing. All right, finance. We'll turn the heat up a little bit again for this one. If there's a boogeyman in medicine right now, it's the money guys. That's private equity, venture capital. You can understand why a community that favors long-term relationships with their local communities are distrustful of people whose vocabularies routinely include exit and scale. Most DPC physicians right now in the community believe that this movement is going to continue to grow grassroots with individual practices run by individual doctors in their local communities. This scenario doesn't require the money guys. Some others, however, want DPC to grow a lot faster and eclipse all the current models of care. For this, VC and PE money may be helpful. Now, just like quality metrics, capital is neither inherently evil or inherently good. And maybe you can call me young and naive, but I'm open to the possibility that the right conversations with the right people can teach us how to properly use capital to supercharge this movement without undermining some of the core principles and philosophy that drive what we do. All right, policy. Let's see if this, so this is a video of my state senator. Cool.
Direct primary care. This is not concierge medicine. These are primary care providers who contract with individuals, oftentimes who don't have health insurance, to provide them with primary care services for a monthly fee. It's an affordable alternative way for folks to get health care.
This didn't happen just because I showed up once in my white coat and explained what DPC is. It took time and it took relationship building. In fact, I've become friends with the senator's legislative aides, and one of them told me that during General Assembly, whenever I would show up, they felt relief at seeing a familiar face after having one-pagers being read at them all day. While there is some benefit in dressing up and visiting your legislator, I believe you can have a much bigger impact if you actually get to know the policymakers and their aides. We have our own specific issues in the DPC, namely in the DPC community, namely having to opt out of Medicare and of course that HSA designation. But there are other areas where we can be impactful in other levels of government. One of the things that DPC is big into is price transparency. In Texas, HB 2002 allows patients to find a cash price and apply that to their deductible. So what that means is if you find a patient an X-ray for $90 cash pay and their insurance in-network is $150, they can then go get that $90 X-ray and then apply that to their deductible. And since the people who introduced that bill are big fans of DPC, there's an initiative now which will allow DPC subscriptions to be applicable to patients' deductibles, building on this current bill. In Maine, they were able to pass a bill that allows DPC doctors to refer and prescribe in-network for their patients with HMO plans. Engaging with the policymaking process can help some of the problems that face our practices and our patients. And it can expose us to other issues where we can have an oversized impact in helping to fix the healthcare system overall. So one of the great things about HINT Summit is the fact that it brings together people from across all these different silos in healthcare. And I kind of want to test that out right now. So when I call on a label that describes you, I want you to stand up, or if you're in the back, raise your hand. And if you feel like you fit into multiple categories, go ahead and stand up for each one. So first, clinicians. Where are my clinicians at? All right. DPC is the foundation of a new healthcare system, and these individuals are the foundation of DPC. All right, next, health tech. Where are all our tech people? Health tech. All right, how we communicate with patients, how we measure quality metrics, and how we innovate depends on the widgets that these individuals build. Finance, any money people? Hey, money people. MHAs, MBAs. All right, everybody, grab your tomatoes, let's go. No, kidding. These people play an important role in potentially supercharging what we do. We need to continue in conversations so that we can figure out how to do that properly. And as a subcategory, you didn't get an icon, but do we have any brokers or benefit advisors? Brokers and benefit advisors. Health plans, awesome. So these individuals are helping us bridge the gap with employers, helping us understand their needs and growing our movement. And finally, any policy people? Hey, there we go. Very good. These individuals can help shape and define what a new reality looks like with DPC at the center of our healthcare system. I challenge each and every one of you to help us better define who we are, progress how we deliver care, and collaborate with everyone and anyone you can. Together, we can make direct primary care simply primary care, and then on top of that, build a truly functioning healthcare system. Thank you all.